Good morning. Once again, welcome to Clinical Trials 101, what every patient should know before enrolling. We're joined by the panelists you see on the screen, also reflected on the slide deck that's up on your screens. And we wanted to make it, take this time and opportunity to share what today's session is going to be about. My name, for those of you who have yet to meet or connect with in person, is Delaney Hines. Pronouns are he, him. I serve as the chair for the Education Committee, and I'm also a member of the board of directors at the SCAGO. I've been a member of the board of directors now going on 4 years. It's been a whirlwind experience, and I'm just so pleased and so privileged to be able to join these opportunities with you folks and share what we'd like to say is a fantastic learning opportunity. I will introduce our speakers momentarily, but before doing that, I just want to take a second to obviously ground today's conversation, being sure to reflect the Indigenous lands from which we hail. Following that, we'll spend some time with a brief intro to the housekeeping, then turn things over to our esteemed guests and esteemed panelists, starting with Dr. Kuo, followed by Dr. Don Richards, and then rounding us out, we have Bochia Champong, who will be great at sharing a bit more about his lived experience and his own perspective. Then we'll have a bit of opportunity for Q&A, and then, of course, closing remarks to send you all off onto a beautiful weekend. So for those of you who've just joined, please know this session will be recorded. It will be available for reference following the live broadcast. You'll be able to find it on our YouTube pages as well. If you go to SCAGO and just search SCAGO on Google, you'll be able to find a link to get the recording within one of our education taskbar options on our website. If you have any questions as you hear from the panelists today, please feel free to use a Q&A or chat feature in order to kind of make sure we get through all presentations in a timely fashion. We'll be able to essentially respond to questions during the Q&A. And if we can't, please know that I'm sure our esteemed guests will be willing to respond to folks via email. Want to make sure I take a second now to, once again, ground ourselves and acknowledge the land from which we're participating in today's conversation. The land in which we're joining you, at least virtually right now. We're grateful for the opportunity to be here, to gather virtually on this land. And we thank the generations of Indigenous people who have taken care of this land long before other nations, groups, and communities came. In particular, we acknowledge the traditional territories of the Ojibwe, the Anishinaabe, and the Mississaugas of the New Credit, whose territory is covered by the Upper Canada Treaties. We also recognize the contributions of the Métis, Inuit, First Nations, and other Indigenous peoples who have made and contributed to shaping and strengthening this province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the present and the future. I encourage everyone, at this session, sorry, to actively seek information and take action in hoping to advance truth and reconciliation. I myself I'm currently residing in Ajax, Ontario. I come to Ajax as a child of immigrant parents who've come from Jamaica. I am also privileged enough to be able to work, play, and live freely on this land. And I do take it upon myself the responsibility to make sure that I am also contributing to truth and reconciliation for Indigenous people who suffered so many unearned disadvantages and the irreparable harm that we're all working towards providing a new and better solution for. So I want to make sure I take that opportunity just to reflect on how important it is we all play a role in truth and reconciliation. Before introducing our speaker, I just want to once again reinforce the SCAGO mission, which is, as you can imagine, serving as a conduit for you, our members, our community, to access and be availed the evidence-based, up-to-date information like we prepared for you this morning to ensure you have the most relevant and timely insight to make informed decisions, not only about your own healthcare journey, but also about the different opportunities, services, and interventions that might be available to you. Today's session is important because, like I mentioned, we have experts on the line who are here to share their expertise with you and answer any questions you might have been, postulating or ruminating on. Today's a day to take advantage. And we hope we can guide you through what would be a very informative orientation to clinical trials, what that means to you as somebody who's lay or new to this kind of area of work, and also the benefits for folks like yourself to participate in clinical trials, not only to yourself, but to the future generations that come. So in this session, as I mentioned, we'll be hearing from Dr. Kuo, Dr. Don Richards, Bo-Chan Chempong. In order to make sure we can hear from them uninterrupted, you will have noticed your microphones have been disabled, at least at this moment in time. and they will be for the duration of the webinar. But if you'd like to ask your question orally, you can raise your hand during the Q&A section, which will follow the three presentations, or feel free to submit it by way of the Q&A feature. Closed captioning is provided as well for those who require that assistance. You can notice that in the bottom toolbar. I can't place it right now, but you'll probably see it whether in the ellipses or at some bottom of your toolbar, you'll see an opportunity for you to activate it. I'll make sure to have that feature put up in a screenshot for the next session. As you can imagine, in order to keep this as a fun and inviting environment, we ask folks to continue to use respectful language in the chat. I know that goes without saying, but we want to keep the conversation on topic. So please do not post other material that's unrelated to today's discussion. We want to make sure folks' learning does not go interrupted. And as best as possible, if you can keep discussions and comments on topic as best you can, that would be greatly appreciated. Uh, we do reserve the right to pause a session or to seek removal of participants who do not abide by these rules. So please, I just ask that we can continue to be inviting and provide a welcoming environment so we don't need to activate any of these measures. So in advance, I thank you for your understanding and agreement to positive participation. One last thing, I promise I'll stop talking after this. Remember that the information shared today does not constitute medical advice, and it's shared with you for information purposes only. So none of the materials shared with you today are intended to be a substitute or replacement for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a condition, a clinical trial, a treatment before undertaking any new healthcare regimen. So we do not want you to think you can disregard professional medical advice in the proper settings, in the proper spaces, or delay seeking it because of something you may have interpreted or heard during today's webinar. So without further ado, I want to invite to the virtual stage our first guest speaker, Dr. Kevin Kuo. He currently serves as the Vice President of Research and Innovation. He's a staff hematologist at the Scarborough Health Network, where he's leading the development of a research institute that focuses on AI-enabled inquiry and innovation in population health, clinical research, and technology-centered education. In addition to his leadership role, he is also an adult hematologist, an associate professor in the Division of Hematology and the Institute of Health Policy Management and Evaluation at the University of Toronto. His clinical focus is on rare congenital, so anemias that are manifested at birth, and his research focuses on novel therapies in hemoglobinopathies and rare anemias, the impact of sickle cell disease on neurocognition, maternal and fetal complications in sickle cell disease, and non-chelating methods to treat and prevent iron overload. So, Dr. Kuo, thank you so much for joining us this Saturday. The floor is yours.
Thank you, Delaney. Really appreciate the very generous introduction there. We'll share my slides right now. Please let me know if you're able to see them.
Yes, they're live.
Perfect, thank you. So today I'm very pleased to share with you on the Clinical Trials 101. So what are clinical trials? Well, clinical trials are research studies that test new medical approaches. Now, these approaches can, of course, traditionally we think about drugs, but in addition to drugs, there could be technologies, there could be therapies like stem cell transplant or gene therapy, or even approaches. It doesn't have to be an actual drug. It could be, say, the way that you're managed at the emergency department, or that when you're admitted to hospital, that there's a certain pathway that allows you to leave the hospital sooner. Other things that people can look at as well are existing medications that have been repurposed for the use in sickle cell disease or in similar conditions. And so these drugs are already have a well-known side effect profile. We know what they do. It's just that they have not been tried in the setting of a particular population or to treat a particular complication. Other things in terms of clinical trials also include new ways of diagnosing illnesses. So why do we need clinical trials? Well, they help us to learn whether the new treatments are safe and effective. How does the new approach compare to the existing options? What sort of side effects may occur, and how we can improve healthcare for future patients. And so every treatment that's available today, almost every treatment, I should say, was tested through clinical trials. And then the next question is, often you hear about what we call randomized controlled trials or placebo or sugar pills, right? That you can either get the medicine or the new way of treating versus the sugar pill or the placebo. And so the question has always been, well, why can't I just get the new treatment? Why can't I just try it? Because I've always had the old way of treating myself. Why not just test a new way? Well, first of all, there's a thing called the placebo effect, and every sugar pills work approximately, it just so happens, approximately 30% of the time. Um, and so you can imagine that if we do not compare it to placebo or compare it to current standard of treatment, then it's really difficult to know whether the effect that we're seeing on you is truly the effect of the new medication or it could be just placebo effect. Another interesting observation that people have made, and this was made actually very early on in the 19th century, and it's sorry, the 20th century, and it's called the Hawthorne effect. So the story goes like this. During the early 20th century, as you know, there's industrialization, people building new cars and factories and so forth. And of course, the factory bosses would really want to see how they can improve the efficiency of these factories. And this was particularly the case in America and in the United Kingdom. And so one very ingenious boss decided to send in a bunch of observers to the factory to see how the workers are doing and to see what sort of barriers they may have and how they can improve the processes. Sounds simple, right? Sounds logical. So when he sent these people into as observers into the factories, he noticed that there was an increase in productivity just out of the blue. And this goes back to the idea that whenever someone is placed under observation, it doesn't matter what kind of observation it is, even if say these observers were sort of hiding in the background, trying to lurk around as much as possible, there is this effect on sort of even subliminally, unconsciously, to have an effect on the environment, on the way that people would act, on the way that people would react. And so we should not discount the idea that just by simply being in a clinical trial, getting a new medication, that there could be this idea of an Hawthorne effect because you're being observed or you're taking something new, and so you feel better, at least subliminally. The other thing to keep in mind, and unfortunately, I feel that this is very ingrained in our culture, is the idea that newer does not mean better. Often we think that, things that are newer, bigger, faster, it's a very sort of North American way of thinking things, right? But more the better. Well, that's not the case. So definitely newer is not better, and so we need to find out whether whatever is new is actually just as good, if not better, than the current treatment. And remember, sometimes less is more. And one of the examples I want to give you is a type of cancer called chronic lymphocytic leukemia, or CLL. Now, CLL in its very early phase, it can be easily picked up by just doing a simple blood test. And then people thought, well, you know what? If we can treat the cancer earlier, then the patients must have better survival. And so the idea then is to do this clinical trial and to test it out to see whether if we treat the people earlier for the cancer versus later, then they get better outcomes. In fact, it turned out that if we treat people early, we can actually shorten their lifespan. We actually cause more harm by treating people earlier for their cancer. So it's actually better. I know it sounds very, very counterintuitive, but you see, often with medications like chemotherapy, for example, there is side effects, right? And sometimes when you give it too early on, the side effects outweighs the potential benefits. So you're actually shortening the person's lifespan. You're actually making things worse. Last but not least is this idea of confounding. And what confounding is essentially is a known or unknown factor that affects both the treatment as well as the outcome. A perfect example of this can be found in sickle cell disease. So there was a study of people with sickle cell disease and acute chest syndrome, right, or chest crisis, as we all know it, by the National Acute Chest Syndrome Study Group in the United States. And when they did this study, it was a single arm study where they looked at whether transfusion helped or, whether it helped chest crisis or not. And they found that the transfusion was linked to severe acute chest syndrome, like chest crisis. And then that's completely counterintuitive because, as many of you know, we use transfusions to treat chest crisis. Well, it turned out that the doctors that were giving the transfusion, and this is where the confounding is, it was to treat those with more severe acute chest syndrome. So essentially, the confounding here is that if you have more by giving the transfusion is given to those who have more severe disease, and therefore there's a likelihood that they have worse outcomes because of the fact that they have more severe disease, more severe chest crisis. So in order to eliminate this confounding, we need to have a placebo control trial. So we need to compare it to placebo. So what are the types of clinical trials? Well, you can see here that in very, very simply, before the phase 1 is what we call the preclinical studies. Preclinical studies usually occurs in animals, sometimes in cell cultures, but there is a certain vigorous requirement that you have to test the medications in animals, and the reason for that is because certain animals are very close to human physiology, and if the drug doesn't even pass the muster, then it's not ethical then to try it out in the human population. So phase 1 is it safe? What's the right dose of the medication that we should use in subsequent trials? And in phase 2, we ask the question, does the medication work? But we also are measuring possible side effects at that time. And often than not, phase 2s, instead of being a single arm trial, meaning that everybody gets a treatment, now there is actually randomization to both treatment as well as to placebo. Now, in phase 3, this is sort of the definitive test, the litmus test, okay, is how does the treatment compare, the new treatment compare to the current treatment, okay? And then last but not least is phase 4. Phase 4 is once the drug has been shown to work in a randomized controlled setting, that it can be used safely and effectively in the population, then once the drug is out of the market, then they will enter phase 4, what we call long-term effects. And the reason is because side effects often happens in a very low rates, okay? They're very rare. And when side effects are rare, it's really difficult to observe in the early phases of trials where there may not be as many people as you would like to be in these clinical trials. And so this is why you need the phase 4. And then the next question you're going to ask is, well, if that's the case, why don't we just put a lot of people into phase 3 or even into phase 2? Well, the idea here is that if you have not established the efficacy and the safety of the drug yet, then it's not fair and it's not ethical for us to expose many patients to the unknown. And this is why we have to do the trials in phases. So what are some of the common study design? So this includes a single arm study. Well, as I mentioned before, everybody gets the treatment. There's no comparison, okay? And often this is done in either very early phase or that, when there's no good comparison for rare diseases. The other one, of course, is the randomized control trial, right? And this is where we randomly assign to either the new treatment or to the comparison, right? The comparison being placebo or the standard treatment. And this is sort of the gold standard way for us to look at whether the drug is effective or not. So what are your rights as a participant in a clinical trial? Well, first of all, informed consent, okay? Informed consent is your right to receive understandable information about the study, to understand the purpose, the procedures, the risk, and the benefits, and to know about the alternative treatments available, and to be given the time to review and to ask questions before deciding. Next is a right to voluntary participation. And that's the right to participate completely free from coercion, pressure, or manipulation, is to make decisions without any threats or undue influence, and to maintain access to the standard medical care regardless of whether you decided to participate in a trial or not. Next is a right to adequate time, meaning that you should be able to take as much time as needed to make a decision, to consult with family, friends, and independent advisors, and to review all materials without being rushed. Next is right to withdrawal, and that means to leave the study at any time for any reason. There's no requirement to provide an explanation, and there's no penalty or losses to medical care benefits. And this decision needs to be respected immediately. Next is the right to privacy and confidentiality. And that's where your personal health information is protected and that data is kept confidential according to privacy laws. Last but not least is the identity of you is protected in research publications, meaning that your name is not going to show up in any of the publications. Next is the right to safety, and that's ongoing monitoring of side effects, the immediate medical care if you're harmed during the study in any way, and that the study will be stopped if there's unacceptable risks. Then there's the right to information, and that's to learn about new findings during the study, be informed of any changes to the risk and benefits, and to access study results when it's available. Last but not least is the right to compensation, and that's fair compensation for your time and expenses if it's applicable, medical care for research-related injuries, as well as clear information about any costs to the participants before you participate in the trial. So what are some of the questions to ask before joining? So in regards to the study, you should ask questions like, what's being studied? What are the phases or the design of the trial? How long it's going to last? What will I need to do? How often are the visits? What tests are involved? In terms of potential risk and benefits, you can ask questions like, what are possible side effects? What are possible benefits? What are the alternatives to me other than participating in a trial? And what happens if I'm harmed? Last but not least, it's about you as a participant. And that includes things like, can I continue on my regular medications? Will I know which treatment I'm getting? Are there any costs to me? Will I be compensated for the time of the travel? How's my privacy protected? Who can I contact with concerns? And will I learn the results of the study? Now, most of these, the trial coordinator would discuss these information with you proactively. So most of the time, you do not need to ask these questions. And then there are times, of course, there's also what we call the informed consent form, or it's almost like a booklet, to tell the truth. Sometimes they're just so wordy that they could be upwards of like 20 pages or more. We try not to do that. We try to make it as clear as possible, but often with very complex trials, we need to be able to convey all the information, all the details in this informed consent package to you. So the way that we lay out the informed consent is often in sections so that you can find this information easily by going through each section. And don't forget, you it's not just about reading through the informed consent, it's also about asking questions, right? So if you forgot about where things are in the informed consent, don't hesitate to ask. Just call the coordinator or reach out to the coordinator to ask your questions. Next, of course, is weighing benefits and risks. What are some of the potential benefits and potential risks? So, potential benefits of being in a clinical trial is to access new treatments before they are widely available, close monitoring by expert medical teams. You be able to contribute to medical knowledge that can help other people, and that you're getting additional tests and screenings at no cost. And there could be a possible improvement in your own condition. And what are some of the possible risks? Well, there could be unknown or unexpected side effects. The treatment may or may not work for you. There's time commitment for the visits and procedures. And, for a limited time, you may be on placebo. Now, often in clinical trials, to mitigate that, is that there's a what we call open label extension, meaning that after you've completed the placebo, if you want to continue on the clinical trial, you can then hop on to the actual medication itself, assuming that the trial is not stopped because of any sort of safety signals. Last but not least, of course, is any sort of inconvenience or discomfort from tests. So the decision is personal. Discuss with your healthcare provider, family, and the research team to determine what is right for you. So now we're going to go through a series of true or false rounds. And here I would require your participation. And Delaney, yeah, thank you, Delaney.
No
So
problem.
question number one, I only have 1 week to decide on joining clinical trial once has been offered to me. So please answer that. And now we're just going to go through all the questions as well. So I'll give everybody a couple of seconds to vote, half a minute.
Perfect. So yeah, as Dr. Kuo advised, please feel free to answer all the true and false questions, and Dr. Kuo will give you the correct response at the 1 minute mark, one by one.
Exactly. Yeah. So I'll give you a couple of minutes to answer all of these questions. So the first one, I'm just going to read them out for people.
Great.
I only have 1 week to decide on joining a clinical trial once has been offered to me. Question number two is, I only have, it's the same one.
Oops, sorry.
Meant to be, it's okay. The second one is, I can ask any questions about the clinical trial. The third one is, I need to pay to join a clinical trial. Fourth question is, getting the sugar pill is worse than no treatment. The one after that is, I can ask about the results of the clinical trial that I participated in. The last one, number 6, is if I have a symptom on a clinical trial, I need to stop the medication right away because it is a side effect of the clinical trial drug.
I realized I missed one question, Dr. Kuo. Apologies. It's once I join a clinical trial, I cannot leave until it's completed. But we can maybe just do
Don't
that
worry
before
about
that.
that. We'll,
Yeah.
we'll, we'll just skip that one, and
Mhm.
and maybe we can let people, we can close the poll right now maybe, and then see where we
Okay.
land. Perfect. Thank you for participating. Really appreciate it. Okay, so the first one, I only have 1 week to decide on a clinical trial once has been offered to me. It is false, and I see everybody got it correct. Very good. So you can take as much time as you need to make a decision. Next question is the one that was repeated, but this is actually the question. I can ask any questions about a clinical trial, and that is true. So this includes any alternative treatment or no treatment at all, as well as the pros and cons with each of these decisions. And remember, newer does not necessarily mean better, right? More does not necessarily mean better. Sometimes less is more. Sometimes the current treatment is better than the new treatment. But this is why we do clinical trials, to figure out whether the new treatment is better or not. Next is, I need to pay, to join a clinical trial. And you're right. Everybody got this right. That is correct. Is entirely false. It should not cost you to be in a clinical trial. And in some rare circumstances, if there is any, you'll be informed for joining. So I'll give you a concrete example of this. So in the gene therapy trial of Exa-cel, right? The current gene therapy trial that has been approved in Canada, during the clinical trial phase, there is a risk of infertility. And so patients were given the opportunity to bank their sperm and to bank their ovaries, their eggs. So the banking cost is all covered by the clinical trial, but there is a limit in terms of, say, the years that is stored, and after certain years that the person will need to start paying. I think it's 15 years or something like that. So so the idea there is that they'll cover for the duration of the trial, which is up to 15 years, but then after that, there is a cost to the person if they want to keep on their sperm or the egg, if they want to keep it banked. So, but you'll always be told prior to joining. Getting the sugar pill is worse than no treatment, and that is false because the clinical trial that you've been asked to participate in is always on top of the standard of care provided to you, meaning that whatever treatment you're getting, you'll continue to get, and on top of that is this option to join the clinical trial. Next question is, this is where, people were sort of 50-50. Once I join a clinical trial, I cannot leave until, okay, yeah, that's the question I think that's
We
missed.
missed.
Yeah.
Yeah.
Once I join a clinical trial, I cannot leave until it's completed, and that's false. You can leave anytime, and you do not have to give any reason at all. Last but not least is I can ask about the results of this is the second last one. I can ask
Yeah.
about the results of a clinical trial that I participated in. Absolutely. Everybody got this one right. And the important caveat to this, though, is that sometimes you may not know, you yourself may not know which treatment you're assigned, even though you know sort of the overall results of the trial, but you don't know exactly which one whether you got the sugar pill or whether you got the actual medication. And the reason is because your care provider, the investigators, right, meaning me or whoever is running the clinical trial, don't know at all. And this is what we call double blind. So I don't know, you don't know, no one knows except for the sometimes it's a statistician, sometimes it could be the pharmacist. But the reason why we don't know is to prevent the bias, right? The confounders that we just talked about previously. We want to avoid the effect of thinking that, oh, you got certain things, and then we start thinking, oh, you know what, your symptoms may be associated with this or that, and we don't want to be sort of affected, right, by knowing which treatment you're on. And so that's called the double blind. And it's crucial. Is actually one of the fundamental sort of principles of which the clinical trial designs are in order to make the results valid. Last but not least is if I have any symptoms while on a clinical trial, I need to stop a medication right away because the side effect of the clinical trial drug, and I see that it was 50-50 here. So please, 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 false, do not stop the drug And the reason is because you need to talk to your care provider immediately before taking action, because majority of the time is that whatever side effects you're suffering from is likely not due to the medication. It could be related to the disease. It could be related to something else that is no relation to either your sickle cell or to the medication at all. And it's important that you contact your care provider. If it's an emergency situation, you have to go to the emergency department right away, like anything else, right? Regardless of whether you're on a clinical trial or not. So you need to treat yourself as if you're not on a clinical trial, in terms of sort of gauging the urgency of whether you need treatment or not. And it's also important to know that sometimes by stopping the drug, you can actually make things worse. Just to give you an example, there's a medication that can prevent the red cells from breaking down. And when people on this clinical trial, and often what we observe is that if they don't stop the medication, they don't suffer as worse of anemia because they're on the medication. But if they have like a pain crisis and they go into the hospital and they stop the medication, often the hemoglobin would drop by quite a bit. And it's because the protection from the medication has been taken away if they were to stop the medication. So with that, I would like to draw to a close, and I thank you very much for your attention.
Thank you so much, Dr. Cole. That was fantastic. And folks, as I mentioned, Dr. Cole will be here till 12:30. So if you have questions and answers, we'll be kicking up the Q&A around 12:15. But without further ado, I want to introduce our second speaker, Dr. Don Richards, who you can see reflected on the screen here. Dr. Richards is both the founder of the 502 Labs and Director of Patient and Public Engagement at Clinical Trials Ontario. She holds a PhD in analytical chemistry from the University of Alberta and brings over 20 years of experience across a variety of roles. Following her own diagnosis with rheumatoid arthritis in 2006, Dawn began combining her passion for science with advancing meaningful patient and public engagement in research. In her role at Clinical Trials Ontario, she's responsible for advancing the Clinical Trial of Ontario strategic pillar of patient and public engagement. She's contributed to both the literature and practice of patient engagement, including work focused on compensation for patient partners, authorship with patient partners, recognizing patients as individuals with diverse skills and full lives, and education on patient engagement in research. As a volunteer, he's the past vice president of Canadian Arthritis Patient Alliance, the CAPA, and is currently a member of the CAPA. She's also a member of the British Medical Journal's Patient Advisory Panel. Great profile, fantastic speaker, great member and family friend of Sligo. Dr. Richards, please, over to you.
Thank you. Thank you, Delaney, for that really kind introduction. Thank you, Dr. Kuo, for setting the foundation. And I know I'm sandwiched between you and Bochi, and I'm going to share some slides and maybe help build on what Dr. Kuo brought to you about the basics of clinical trials. I've been asked to focus a little bit more here relating to access and equity. As Delaney said, I'm here on behalf of Clinical Trials Ontario. We are primarily funded by the government, and really it's our mission to help make Ontario a better place to do trials. And as Delaney mentioned, I'm in charge of the strategic pillar related to engagement. And that means helping people make decisions, informed decisions about participation in trials. And that also means about working with patients and their families and communities in the work that we do and encouraging people in the trial space to do the same. So there's definitely a link between access and equity in clinical trials. I kind of think that at the heart of creating equitable trials is about creating clinical trials that anyone who wants to participate in a trial has the opportunity to participate in. So that means that potentially more people can access them because they're easier for them to be able to participate in. It's probably a no-brainer that potentially leads to more diverse participants being not only able to participate in those trials, but being able to complete those trials as well. And that has positive impacts on the efficiency with which we do trials, and importantly, on what we call the generalizability of results. So if we don't have diverse participants in trials, we've got results that really are only from one segment of the population. And to be concrete about that, in the cardiology space for many years, there's been an emphasis on white men as participants in cardiology trials. And so what that means is things that have been tested in trials, we know how they work in white men, but we don't necessarily know how they work in other populations. So us doing a better job in the trials community of bringing trials to other people to be able to participate is really important. So I'm going to talk less about specific trials and a little bit about what's happening in the trials community generally around equity. You don't have to know what each of these things is right now. I'm going to talk about each one of these for a few minutes. A big part of what we're seeing in the trials community is partnering with people who live with the conditions that trialists are studying. You know best what it's like to live, for example, with sickle cell disease, and understanding your day-to-day and what it's like to live with sickle cell disease or around a loved one with sickle cell disease can really make a difference in terms of how research and trials are designed. Understanding perceptions around trials helps us build better trials. And that might mean implementing decentralized or hybrid or remote or virtual components into trials. I'm going to share some information about the importance of sharing lived insights with those who set regulations, with those who support the clinical trials environment, and even those who fund clinical trials. I'll talk a bit about what's happening in the sickle cell area around some global collaborations, and I know at least one person in the audience who's involved in that work, and I'll share a few other things. So Dr. Kuo has shared really specific things about trials and maybe participating in trials. I'm going to take you a little bit farther outside of the space and just share some of the things that might be important for you to know about that's going on. So the first thing I'll talk about again is partnering with patients, caregivers, and families and communities. And sometimes we call this patient engagement. Well, you might think patient is specific to somebody who lives with sickle cell. It can also refer to caregivers, family members. You all bring perspectives around what it's like to live with sickle cell disease or what it's like to live with someone who has sickle cell disease. And what patient engagement here is about is it's not about participating in research. It's about contributing to research projects and how trials, for example, are designed. So that's being a partner on a research team. And it's about sharing your lived insights so that research can really be around priorities that are important to the sickle cell community. It's about understanding what the day-to-day is like so that when studies are designed and built, that's taken into account. And you might even have a role in doing parts of the research and in disseminating the results of the research. So patient engagement, where patients are partners on research teams, has both potential benefits and risks. I've talked a little bit already about some of the potential benefits. So helping identify important research priorities for patients and their communities. And when those lived insights are taken into account to design the research, it means that those aspects of the research study are built so that teams can minimize the burden of participating. That in turn leads to improved enrollment or recruitment to studies and keeping people in studies. And like we're seeing here today, it means help in disseminating results. And the team grows and learns together in different ways. There are potential risks too. So as someone from the sickle cell community, research can take a long time, and you might suggest things to the research team that for some reason can't be built into the research. You might relive painful or even traumatic experiences with being involved in that research as a team member in hopes that others don't have to go through what you've gone through. Researchers aren't usually trained to engage patients and their families as partners, so it's a learning curve for them too. And there's a bit of research done to date that patient partners tend to look like me, upper middle class white women. And that isn't exactly a diverse group of patient partners. And so those are some of the potential risks about doing research this way. Delaney mentioned that part of what SCAGO does is bring the latest research and evidence to its community. We've had the privilege of working with SCAGO and on some research that we've done at Clinical Trials Ontario with researchers from the Ottawa Hospital Research Institute. And so we have actually published on that, and this has been specific to understanding the sickle cell community's perceptions of clinical trials with the hope that we can help the community build better clinical trials, knowing what the perceived barriers are to participating in clinical trials or other types of research, and what people see as the enablers to do so. So if you look down below here, the biggest barriers we found from talking to the community are that there might be invasive tests and procedures as part of clinical trials, and that travel to a study site can be a barrier. Some of the enablers, though, are the opportunity to help others and the opportunity to offer hope for sickle cell disease cure, which we're starting to see actually as well. So when researchers and others on research teams, including patient partners, know what both the barriers and enablers are related to a community that they're working with, it can really help them design better studies, taking these into account. The other thing that might help people to be able to participate in studies who maybe haven't been able to in the past is what we call decentralized or hybrid trials, or you might hear these called remote or virtual trials. So traditional clinical trials are sort of centered around the research team. And that's where you go to a central site. It might be a research center, it might be a hospital or a clinic. You have tests done there. You might respond to surveys or questionnaires there. You sign the informed consent document there, your approach there. So you're part of this kind of whole system around the research team. With the concept of decentralized and hybrid trials, which really gained a lot of momentum and uptake at the start of the pandemic when safety was really a concern, the idea here is that the model is sort of shifted so that a participant is more at the center of how the trial works. And so people might come to your home to deliver the drug or other intervention. You might take part in the informed consent conversation using technology. You might even sign the informed consent form using technology. You might have a study diary and surveys that you respond to online, or maybe closer to home. Maybe a research center that's closer to home or a lab that's closer to home. And you may or may not even have to go into a central site. So a fully decentralized trial, you do everything from home or closer to home. And hybrid trials or research studies have some things that you do at home or have people coming to see you. And sometimes you go to other sites. Again, you might call these, or you might hear them called remote or virtual studies. And we know for some people, there are real benefits to there being decentralized or hybrid parts of clinical trial. And if you're interested in a trial or a research study, you can ask about this. You can ask about what your participation looks like and maybe where that participation is located. So we know there's some potential benefits for people. It might be more convenient for them. You do stuff from the comfort of your home or more in your own community or neighborhood. Some people are super comfortable with technology and using technology. This is a way potentially to increase diversity of participants in studies. For some studies, we've actually seen a lot faster recruitment And we've seen that participants stay in the studies when it's easier for them to participate sometimes. Just like other things, there can be challenges to doing studies this way, not only for participants, but for the people who are doing studies, like Dr. Kuo and his colleagues, and maybe sponsors. For some people, they want to be interacting all the time with the same people within the study, and that might not happen through these types of studies. Some people are really concerned about privacy. So if I do things over Zoom or with technology, there could be a risk. For some people, they see the technology as well as maybe some of the other responsibilities of participating in studies this way as a burden. So for example, in some studies, people are trained to take measurements that they wouldn't usually take on their own, but they may be helped over Zoom, and they might be trained at a main site, and then they would do the other measurements on their own. For some people, technology is not their friend, or they might live in areas where they don't have great internet access, and this becomes an issue for them. And then there may be other people who are involved in data collection as part of the research that wouldn't normally be involved in collection. And so third parties that are hired to do some of the work in these types of studies. So there might be more people interacting with the data, and some people get concerned about the quality of the research when trials are done this way. We've done some research at Clinical Trials Ontario about people's perceptions in Canada of decentralized and hybrid trials. So we did an online survey. We collaborated with people, some people who participated in trials themselves, others who haven't. And I have to admit that our participants weren't exactly the most diverse. So we had an overwhelming response from people who are Caucasian. We had more people who had participated in trials than people who hadn't participated in trials. So those are some of the limitations of our study. But knowing that, some of the main findings we found is that with respect to informed consent, our respondents had a preference to do this at a site close to home. They were generally comfortable with technology, and about half were concerned with privacy of doing informed consent outside of doing face-to-face in real life, versus those who were okay with using technology. In terms of participating, most people wanted to do routine or simple tests closer to home. One of the really key things for them, though, is having contact information if they had any main issues. And most people wanted travel to a central site if they had to go in to be under an hour. For delivery of drug, most people were fine with it coming to their home or them picking it up somewhere closer to home. The main things there were having really clear instructions either about delivery or how to administer the drug, and the communication around that. And then the overwhelming majority of people thought that doing studies this way would improve accessibility for participants and also improve the diversity of participants, so that a range of different people could participate, no matter if they were in a smaller center or a rural center as well. I'm going to shift gears a little bit. You may not be super interested in this, but I think it's really important for you to know that SCAGO is out there sharing your insights and your lived experiences anonymously from how they've interacted with you, as well as with other communities, to our regulator, which is Health Canada. So that's the regulatory agency in Canada that oversees everything related to clinical trials. Even with the World Health Organization and with the Canadian Institutes of Health Research, so our major federal health research funder. CTO has done a number of submissions to open consultations that these agencies have had since 2020. So we've responded to 9 of these. And the ones that I just sort of wanted to talk about a little bit is there have been consultations related to the diversity of demographics of trial participants. And and whether or not that information is actually collected right now by people doing studies, and why it's important to actually collect that type of information on people. So we know exactly what participants look like who are responding to new therapies or not responding to new therapies. The responsibilities for trial teams to share trial results. Dr. Ko talked about the fact that you can ask to understand what's happened in the trial. Not everyone publishes about what's happened in the trials. And there's data on that to show that there's kind of an overwhelming skew of people sharing positive trial results and not necessarily other types of trial results. And there's even this concept in Canada of expanded access trials. And that's related to when people don't meet strict eligibility criteria, that there may still be ways for them to participate. So I also wanted to let you know that we know that our submissions are having an impact because we've seen things move from draft guidance or documents to the final documents and guidance documents. And we've seen some of our ideas make it into those final drafts, sometimes even verbatim. So I really just want to emphasize that you being involved with SCAGO and you sharing your experiences and insights with SCAGO, whether you know it or not, actually trickles up to decision makers. And it's really important that they hear from you about what your experiences are. Lastly, I've been really privileged to be part of some work that SCAGO is doing with GANSID, the Global Action Network for Sickle Cell and Other Inherited Blood Disorders. And we're working really hard as a global community to help make sure that anyone globally who wishes to participate in these kinds of clinical trials ultimately has access to these. And a lot of that has to do with building capacity in different countries in order to be able to do that and collaborating together. There are other things I don't have time to talk about today, but there's a lot going on with respect to building capacity on trial teams relating to equity, diversity, and inclusion, and us better understanding in the trials world that if you see people on trial teams that look like you and maybe have some of the same experiences that you do, that changes how you trust the research teams and how you interact with research teams in a good way. There's lots of stuff that's happening that I don't have time to talk about to bring trials to smaller communities and rural areas, and also to community hospitals that often aren't able to be part of clinical trials. There are discussions happening about eligibility criteria and the fact that many people have other things that are going on that mean that they don't necessarily meet the strict eligibility requirements for trials. And there's lots going on to make trials more efficient, which are things you don't necessarily think about. But if we can help make trials still be safe, still be ethical, but start up more efficiently in Canada, that makes Canada more competitive, and that brings more trials to Canada, which means that brings more trials to people who want to participate in trials. So what does this all mean for you? There's lots that's going on in the trials community to create trials that are more relevant for people with sickle cell disease and that decrease the barriers to participation. Diverse participants in clinical trials means that the results are more generalizable. And I really want to emphasize that your voices are being heard by regulators, policy and decision makers, research funders, and researchers and trialists and others in the trial community too. Like the others on the call, I'll stick around for a Q&A, but I'm also really happy for you to reach out to me after today if you've got any questions at all. If you think you might like to be a research partner or learn more about that, I'm happy to talk to you about that. And I'll also put my email in the chat so that if you don't get a chance to get it here, you've got it somewhere else. So thanks very much. I really appreciate the opportunity to chat with you today.
And we really appreciate you, Dr. Richards. Thank you so much for that fantastic presentation. Not to be understated, there's a lot of great information that's been provided. Once again, we'll have folks be able to provide some answers to questions as they flow in. Our next speaker not to be, we saved the best for last. Mr. Bochi Achampong is joining us to provide us with not only his own personal experience, lived expertise, honestly, and providing a bit of a patient lens on the topics that have been discussed today. He's a new member to the Skego family. We're really happy and pleased to have you join us this morning, Bochi. So I don't want to steal any more of your shine. Please feel free to walk us through, in your own words, how clinical trials have impacted you personally.
Well, to begin with, I was born with sickle cell, specifically SC. Um, the sickle cell I had affected my eyes as well as my body. Um, when I was about 5, I went through clinical death. When I after to get, once I got out of once I was revived, I had to do blood transfusions for about 2 to 3 years. Um, then that stopped, and then after that, I had a splenectomy at the age of 9. At the time, they felt removing your spleen would decrease the chances of your crisis. Uh, from then, um, from then on, at around the time that I was about 16, 17, I started experiencing sickle cell retinopathy, where your eyes start to bleed, um, all while dealing with physical pain. Through my elementary years, I probably spent 2/3 of my time in the hospital. So most of my education was in Toronto Sick Children's Hospital. High school, I would probably say a third. And during college, university, I would say that that decreased to little than a quarter for the 4 years I was in college and university. And in adulthood, that decreased altogether. Part of that was because uh, I dealt with it by taking 2 extra strength Tylenols and 2 extra strength Advil together, 4 pills, every 3.5 to 4 hours, 4 times a day. Um, as I got older, from a child to adolescence to adulthood, my threshold of pain was increased. That said, it didn't mean that the pain was any less severe. Um, the only time that I started going to the hospital, it wasn't for joint pain. Usually I would just carry through. As you know, with sickle cell, can't afford to miss work. But when the sickle cell crisis affected my chest, then I would definitely have to be hospitalized and basically sit down, uh, be hospitalized for at least two weeks. Um, so I spent most of my time living with sickle cell and trying to find some sort of normalcy within the physical pain that I would endure throughout my life up until 3 years ago when my sickle cell retinopathy hit critical mass, where the doctors told me that within 10 years I'd have permanent retina damage and basically I'd go blind, and that would be it. At which time that I got approached that there was some trials going on, and I if my sister was a genetic match, I'd be eligible for a cure. Um, my sister turned out to be a genetic match, and I moved forward without hesitation. Part of it was because a basketball player, I'm really into the NBA, by the name of Carlos Boozer, has a son. Um, there's a there's a segment on it you can find on YouTube called Blood Brothers, ESPN, where his first child had sickle cell, and they ended up having 2 more children, twins, wherein they used stem cells from the twins to cure their eldest child. Um, the twins, one of them is one of the top college players in basketball, and he's supposed to be at least a top 3 pick in the NBA. But I digress. The fact is that happened when the story came out, that was in 2008. So I was able to see what happened to the eldest son, and he lived a normal life. So that's why when I did the trial, I did it without hesitation, um, and utmost confidence. Um, I've been cured for it will be 3 years in April. Um, and the difference is night and day. I'm 50 now, 51 to be more specific, and this is the healthiest, the strongest I've ever felt in my life. I breathe better. Um, I sleep better. I don't suffer through shin splits that I used to have these pains that I would always have at the end of the night and have to really take painkillers just to go to sleep because they were sore. And I used to think just my shins were frayed or cracked or whatever. It wasn't the case. It was just sickle cell crisis um, that I just dealt with. And like I said, the difference is night and day. Um, I'm the baldest scapegoat as well as various other groups because I want to pay it forward, and I do feel uh, everybody, if anybody, I mean, if they're eligible, should try and get these trials. I also feel that sickle cell, again, based on I wasn't sure before I was cured, but now that I'm cured and it's going on 3 years, I do feel sickle cell should be seen as a disability because we are living behind the eight ball when it comes to just our daily lives, uh, going to work, the exhaustion part, doing a 10-hour shift, sometimes overtime. There was a time when I was in my 20s where I did, the 52-hour week working a 9 to 5, and I did night school 5 nights a week, and I also did two 12-hour shifts on the weekend security. I didn't I didn't need to have muscles. I just needed to like call the police if anything. But I was at a hotel. But I used to extend myself that much because of the cost of living in Toronto. And as you know, in sickle cell patients, when you enter the workforce, uh, there's not much grace when you need to take time off for sickness, and it's worse when you don't have a stable job and you're in a probationary period to deal with that. So, but I'm going off in a tangent. Yeah, the trial's been amazing. I've had an amazing experience with Dr. Kumar, Dr. Ko, um, and that's pretty much my story.
Man, first and foremost, Pochi, I thought you were younger than me. So whatever your skin regimen is, my brother, you're doing a great job because I had no clue you were pushing 51, but great. Keep up the good work. Secondly, thank you so much for sharing that really full and comprehensive walkthrough with your journey. It touched me just to hear how much life has changed for you in the last 3 years. To see the clinical trial and your sister being a donor was a possibility for you. I'm so blessed. Sorry, I'm so happy to hear that blessing was delivered to you, and I'm glad to hear that you're in a state and frame of mind now where you can kind of impart this wisdom to folks on the call. Thank you. And once again, we appreciate you and can't really say anything more than just happy and encouraged to see you here and being able to participate in sessions like this with us. I don't want to steal any more shine from folks on the line. Now's the time for any questions you may have. We have 17 minutes remaining. Please, if you have a question and you want to speak directly to one of our panelists, you can raise your hand. Alternatively, if you've had a question you've been sitting on, please feel free to enter it into the chat and I can orate it for you. Maybe while folks are getting things started, Dr. Kuo, I had a question to you. You talked a bit about the single arm versus the randomized control trial. And what stood out to me was the idea that single arm trial didn't have like an evidentiary or historical kind of comparator. So they don't do the placebo in those trials because there's not really a history there. So for people who are trying to understand what trial is better served to participate in, is the lead up to either the single arm or RCT the same, like in terms of the risk and benefit analysis?
No, that's a very, very good question. So there's a couple of scenarios that we need to think about here. So typically, I'm going to talk about typical scenario. Typical scenario is that in phase one and phase two, they are usually single arms. In phase three, where we think about it as sort of the litmus test, right, to see whether the drug truly works or not, that's usually randomized control trial. Now, there's benefits and sort of risks to each of these, right? So if you have a strong conviction You know what? The way, actually, you know what? Let's step back. The way I kind of put
Okay,
it is like an early adopter of new technology.
got
Are
it.
you an early adopter or not? Are you the person who actually will go line up at midnight for that new iPhone or for that new Google Pixel? Or are you someone who likes to hang back, let all the bugs fix first before buying that iPhone, right? So if you're the former, then there's advantages in joining the single arm trials because those one you're guaranteed to get the new medication, but you really have to have the conviction that the new medication you think is going to work for you. Okay. And
Beautiful.
you have to sort of take that risk in thinking, well, the drug, is there's more benefit than risk. At least you think that is. Again, we don't know, right? This is why we're doing these trials. Now, if you're someone who likes to sort of hang back and say, well, you know what, I like to let other people go first, iron out the bugs, complain to Apple about all the problems that they have with the iPhone, and then I'm going to get my iPhone after, then the randomized control trial is better because you have a chance of not being on the new medication and just stick with currently how you're being treated. And you still have an option of going on the medication afterwards in the open label phase.
Beautiful. Thank you, Dr. Kuo. I'm going to get right back to you because there's some questions coming in through the chat. Boch, this is a great question from one of our panelists. And Dr. Richards, don't worry, I have questions for you too. But this one I want to get to before folks drop off.
Shoot.
After going through a clinical trial and being cured, what advice would you give to patients who are eligible but feel unsure or overwhelmed?
I'd say do your research. Again, my my personal point, again, I'm into basketball and NBA, is Carlos Boozer. The
Right.
Blood Brothers series segment that they did on ESPN 360. It's on YouTube. Um, and that whole journey and experience that he had with his sons. And again, I saw that in real time. And at that time for that trial, he had to pay like $3 million, just under $3 million, just to have that done for his son. And I think it happened around 06, 07, but the actual segment article came out and piece that they did on ESPN came out in 2008. And so I got to watch that whole story as well as his NBA career. And then they did a full circle moment with it about 2, 3 years ago. And so based on that, that's where my confidence came. And you get to see their journey, and it's very heart wrenching. But and of course, I got a chance to speak with a couple of people who did the trial before me. Again, I was number five, so I got to speak with uh, one or two others that experienced it within Toronto. So based on all that, that was why my confidence was so high to move forward. I
Great
hope
answer.
that's answered.
Yeah, I hope so too. If there are any follow-ups, please do feel free to post them. But what really resonated with for me was you said it perfectly. The opportunity cost or the opportunity to participate in 06, 07 was $3 million at that point, right? And now the accessibility and the barriers to participating in these trials may not be that high anymore. So it's to your point, at one point in time, somebody was willing to pay that much money for a chance to find a cure. So, take that for what you will, but it's an opportunity that I think these trials are really providing folks with new vantage points. Don, I was wondering if you could speak more to you mentioned in that trial, that study you shared that there were repeat participants that came from like, white kind of community, Anglo-Saxon speaking communities that did trials more than once. So I'm wondering if does that essentially lend itself to say that people are having positive experiences with clinical trials?
I think just to clarify, when we did research, Delaney, with our survey, we had an overwhelming response from folks who, yes, had mostly participated in research previously and tended to be upper middle class people. There's actually two things there. I think that's happening. One, we did an online survey. There's actually data that people who look like me tend to respond to surveys more than other people. So, despite our best efforts to try and diversify the participants there, we weren't so successful. I do think too that part of why we saw so many people who have participated in trials before respond to our survey is
Mm,
a little bit about being in the know about things too. So part of how we disseminated our research and our survey to people was through groups like SCAGO, and through other patient organizations and health charities, where we know that the communities are really interested in research, and maybe are a little bit more prone to participating in research than members of the general public. So those are some kind of caveats around a bit of our findings. But I do tend to agree with you, Delaney. I think that once people learn a bit about research and if they've had a good experience, I think there may be, and I don't know the evidence on this, but just
fair.
based on conversations I've had with people, you're a little bit more open to the idea about it, and you're maybe you understand what some of the some of the benefits might be for you. They might not be related just to the specific trial or like the treatment that's under study. But I think Dr. Kuo made a point too about when you participate in a trial, and I've been in a trial, you do get access to care that you might not get access to when you're not in a study. You get yeah, you get access to other things that you might not otherwise get access to. And for some people, that's a benefit.
Beautiful. Thank you, Dr. Richards. Dr. Cole, back to you, and I have a two-parter. One person's asking, I mean, maybe you could lend itself to the Scarborough Health, the trial you're currently leading at Scarborough Health Network as well. But they're asking, is there an age restriction to participating in the trial? And I guess that's about one of the eligibility criteria. And then the second question goes back to what developments in sickle cell research are you most hopeful about that are still early or widely not discussed yet?
So, regards to the age limit, certain trials do have age limit. And the reason for that is because of that we think sometimes that the drug may work better in certain age group versus others. And second of all, children are often tested sort of second. We test the medications in adult first, and the reason is because of safety. We want to protect children. Sometimes pregnant individuals are also excluded in the study. Now, having said that, these can sometimes cause injustices, right? And can cause imbalance in terms of representation in trials. So a lot of drugs, for example, even though that there's just no evidence of using them, even though they may be helpful for pregnant individuals, they have never been tested, and so we can't use them in pregnant individuals. Similarly, in children, and so the uh, the sort of the paternalistic effect of an attempt to not cause any harm, the attempt to to provide protection for a segment of our populations can sometimes translate into injustices,
Good
and
question.
it's a very difficult thing to grapple.
So I wanted to, and I'm going to remind you of the second part about developments happening right. Actually, no. Let's continue that thread on the injustices. We had a question that just came in that there's, historical evidence of mistreatment and malpractice in the United States, thinking of Henrietta Lacks, the Tuskegee syphilis trial, etc. Do we find past history might be a barrier in Canada for members of equity deserving or BIPOC communities to participate in trials? Maybe Don, I'll maybe kick that one over to you, and then if Dr. Cole, you have any thoughts as well, that'd be great.
Yeah, I would say absolutely we do. And to be brutally honest, we see this in Indigenous populations as well in Canada. There is a history and an ongoing history of medical harms and racism, and that also spills into research. And so, yes, we see that. And I think part of what SCAGO is doing is trying to build trust and maybe dispel some of the myths. But I think there are completely valid reasons for mistrust within certain communities of the medical and research establishments.
Well said. Dr. Cole, back to you. If
Yeah.
the treatment, oh, sorry, go ahead.
I just
Apologies.
want to add that in
Mhm.
Canada, one specific example I could think of was in McGill University during the 1960s, when one of the psychiatrists was actually a CIA agent. And he ran a series of program called the program Ultra that led to the administration of drugs like LSD and other types of psychoactive drugs on people who were being treated for depression. And they were under the guise of a clinical trial.
Good. I'm gonna read more about that later. I didn't know about that. Um, wow, that one kind of set me threw me for a loop. But okay, back to the questions I see pouring in, Dr. Cole. One really intriguing one. An individual asked, if the treatment during a trial works for them, will they be able to continue it after the trial ends?
That really depends. Some trials do offer what we call open label extension, meaning
Right.
that you get to access the medication continually afterwards. And then some are called expanded access. There's different names for this. But in general, the practice is to offer the medication after the core period has ended. And this is both an ethical approach, right? Because we want to be able to offer the opportunity of those who have bravely and participated in the trial an opportunity to benefit, personally benefit from it if they are indeed getting benefit. And second of all, it also provides sort of sort of longer time period data that's of benefit to other patients as well, because this will allow us to collect more data to understand whether the drug has any sort of potential side effects, sort of
Beautiful.
long and sort of longer time period.
Okay. Another great question is coming, Dr. Coleman. Stay with you. If something happens while on a clinical trial, like a complication or a side effect,
Mhm.
who does the participant contact first? The trial team or their own doctor?
Very good question. Excellent question, actually.
Yeah.
Safety's first, okay? So if you're experiencing any sort of effects, whether it's related or not, and the important thing is that we often don't know whether it's related or not. So the
Mm,
first thing to do is how emergent is it? If you're having shortness of breath, if you're having chest pain, that sort of emergency symptoms, type of thing, go to emergency department immediately. Okay, your
right.
nearest emergency department. Treat it as if, and always think about it like this. Always treat it as if you are not on a clinical trial. Don't think just because you're in a clinical trial, you think of it differently. The
Good.
additional thing you have to do, though, is to contact the person on that. Usually it's listed on an informed consent form. Sometimes you'll be given a little card in terms of who to contact on emergency. Yeah, so it's sort of the two-parter, right? Treat it as
Yeah.
if you're not on the clinical trial, plus contact the clinical trial personnel, the contact information that you've been given.
Beautiful. Bochi, actually, I want to ask that same question as you as well. Having gone through a clinical trial, were there moments where you came across these kind of decisions and how did you navigate them?
Uh, Decisions like what? Yeah.
So, ever coming up a point in time where you felt unsure of what was happening whilst participating in the clinical trial, and how did you like navigate those moments? Or if not, that's
No,
fine too, you know?
there wasn't any just because again, um, I think I told you that I experienced clinical death when I was around 5, 6. From that, at that point, I was living in Rexdale. The hospitals in the West End weren't that knowledgeable of sickle cell, believe it or not, and it was a predominantly Black area. At that point, they had to fly me to Sick Kids, and at that point, my mom moved downtown. So my whole experience with having sickle cell has been with the UHN network. So much so, I could be in Hamilton or New York. If I get sick, I'll just endure the pain until I get home and I get to go to Sick Kids, Toronto General, and whatnot. So, being that I was cured in Princess Margaret, after Sick Kids, I went to Toronto General. It's all UHN network. I just had a trust for the UHN network, and that's based on uh, that was based on 45, 6 years. So,
Right,
um,
right.
now, when you're talking about most people, like I didn't, and believe it or not, I didn't know there was a separate there was separation between hospitals. So, there's certain St. Mike's and St. Joseph's are different than I didn't know there was separation. And there are separations in different provinces and different cities and whatnot. So
Mhm.
I mean, because I grew up downtown, literally Elm Street University, right beside, right behind right across the street from Sick Kids and right behind Mount Sinai. Um, all I know is UHN network. So I do, my heart does go out to people who have a disjointed experience because they're dealing with one hospital one day, another hospital another day, and all those hospitals are separate in their sharing of knowledge and sharing of information. And so that's what makes it complicated for people's experience. And so when you go, if I go to UHN network as a sickle cell patient, besides the waiting to register my name, usually I don't wait more than an hour and they already know what to do with me. Now, if I was to go to a different hospital, I would go through the I would go through a lot of the red tape that would they would give every patient that comes to them. So I say all that to say just I had a trust for the UHN network and I've always gone out of my way to just deal with them, no matter where my journey took me as far as career wise. So
Beautiful.
I hope that answers.
Absolutely does. And just for folks on the line, that was not a paid ad. That was true and genuine from Bochi's words himself. So I think the important thing there as well is the relationships matter. Building trust is important, and that's something you can do over time. I know we're at time, but I want to kind of close on one final question to the group. And it was an individual asking for Dr. Quob. I think it lends itself to yourself, Dr. Don, and Dr. Richards and Bochi about what developments in sickle cell research or clinical trials are you most hopeful about that are either still early on or widely not discussed at this point? I know it's a bit of an open-ended, broad question, but what excites you about tomorrow and the opportunities that have yet to be fully realized? Maybe I'll start with Dr. Richards.
So I'm not the specialist in this area, but I can tell you when I first read about the cure, I think that that was amazing. That's obviously not going to be accessible to everyone right away, but I think it represents a major breakthrough. And then some of the things we're doing closer to home related to decentralized or virtual or remote trials, having trials be done in community hospitals that aren't necessarily usually hospitals that undertake trials. Like bringing trials to people where they are, for me, is as a trials nerd, is really exciting.
Fantastic. Thank you for that, Dr. Richards. Dr. Quell?
Yeah, so there's a two-parter to this. First part is from a technology perspective. I'm very, very excited about a type of gene therapy called in vivo gene therapy, where you can get essentially an injection or infusion, and then it'll correct your stem cells, the genetics in your stem cells. I think that's very exciting because then we can avoid, be staying in hospital for 30 days, getting chemotherapy, getting all the side effects from the chemotherapy and so forth that you need before you get the gene therapy. That's still at a very preclinical stage right now. So right now, we're dealing with tissues, human tissues and animal models and so forth, but hopefully that's going to come very soon. The second part is about access. I think accessing clinical trials has always been very difficult, but with the new ways of conducting clinical trials, like the way Dr. Richards has just talked about decentralization, I think that's going to increase the accessibility. I think there's still a fine line in which we as investigators walk, meaning that we would love to tell everybody about all the clinical trials that we're doing, but we need to do it in a way that we're providing information and not advertisement. It's important that we do not, advertise in any way, and it's a very fine line to walk. So if you find that a lot of times the information may be a little subdued or mundane, when new clinical trials are announced, is not because we are boring people. It's because we don't want to cause any undue influences on people. We don't want to make it look like as we're selling something or advertising something.
Beautiful. Thank you for that, Dr. Quell. Boch, I want you to have the last word. It doesn't have to be specifically in this same thread, but if there's one parting piece of wisdom you can leave with folks, we'd love to hear from you.
I spent my whole life, 48 years living with sickle cell anemia. You know, I used to wonder, why would God forsaken me? Why was I born with an expiry date? At that time, I wasn't hopeful for kids with sickle cell anemia. I was often told from a young age, this is again the late 70s, early 80s, children as well as adults and teachers will say, hey, you're supposed to die soon. So almost, you don't need to try that hard. I did. Uh, Luckily, I had enough confidence based on my parents, my family support where I had a lot of confidence to do whatever I can to maintain my health. Because of that, I didn't drink, I didn't smoke. I tried my best to work out, but to go through life thinking that you would just live with this pain and to one day in your late 40s, be cured, you know, it just tells you God is good. There's hope, it tells you, it shows you that, you see these Princess Margaret hospitals, they always run the lottery. You could get a big house and you think that money is just going, is a hustle, it's a scam, and they're just taking your money. But, you know,
Mhm.
I was cured. I was put in a room with where people have been cured from cancers, all types of cancers. And, you know, I've heard of the Tuskegee stuff. I do know what's going on in the hospitals across the US as well as Canada. But there are good um, health workers out there. Uh,
Mhm.
Again, I'm Team UHN, um, so there is hope, and a lot of people are. I mean, a lot of people are not. They're actually trying to cure a lot of these ailments that exist in the world, and you know, that enough should give you hope and faith that God is good. There are good people in the world, and they do want to see you do better, feel better, and live a healthier, fruitful life. So I hope that
I couldn't have said it better myself.
yeah.
So with that, folks, thank you so much for spending your hour and 36 minutes with us. Thank you to Dr. Kuo, Dr. Richards, Bochi. Your wisdom, your expertise, and your grace has been so deeply, deeply appreciated. To folks on the line, as mentioned, if you want to review this content at your leisure, please visit us at www.sicklecellanemia.ca. This is the first in a series of Learning for Life session we'll be delivering this year. Tell your friends, tell your family. We're continuing to see you coming out. And with that, I wish you all a great rest of day, a great rest of weekend, and a great rest of 2026. Thank you all so much for joining us.
Thanks for
Take care.
inviting us.
Great.
Thank you.
Thank you. Take care.
Goodbye,
Bye.
folks.